facilitate. Without further work, let's dive in. Dr. Burchell, thank you for joining us. The remaining time is up to you.
Thank you very much for inviting me, and yes, thank you to all of those of you who have joined me here in Australia, where it's nighttime, wherever you might be in the world. This is a very big topic, and I guess quite hard to condense into a 1 hour webinar. But I guess I thought what I would do is I would try and focus on a few things that I think would be relevant to you, and regardless of your level of experience and how many rhinoscopy or upper airway procedures you might have done. Even if you've done quite a few of it, hopefully you will find this helpful. What I'm essentially trying to do is share some insights that I've gained in terms of trying to perfect your skills from a endoscopy point of view. And hopefully what you can take away from this is a good idea of what the scope, no pun intended, of endoscopy is as it pertains to the upper respiratory tract. So I thought I'd start off a little bit with some basic anatomy. Because endoscopy is a visual diagnostic procedure, it helps to have a basic grasp of the anatomy of the species that we are imaging. Endoscopy is a direct form of imaging, unlike indirect forms of imaging, X-rays that we're very familiar with, or ultrasound, where you use physics to generate an indirect image. With endoscopy, we actually are looking directly at the structure that we are wanting to visualize an image. And when we are trying to evaluate the respiratory tract of one of our dogs or cats, it helps for us to have an idea what the basic anatomy is, but also a large part of the, or a large contributor to the issues, the respiratory issues that we see, particularly with dogs, to a lesser extent with cats, but particularly with dogs, has to do with the effects of breeding on anatomy. So dogs have been bred or have evolved from a common ancestor, which would have been a wolf, similar to the grey wolf. And we have, through selective breeding, taken that animal and bred dogs ranging from flat-faced pugs to small chihuahuas, all the way to Great Danes, like I have. And the effects of domestication and the effects of the selective breeding have had an impact on the respiratory function of these species and have a bearing on how we evaluate them and how we manage them. So we're going to start off at the front, because we're going to move our way through from the nose all the way down to the airways. The airways are a complex sort of set of narrow passageways that pass through from the nostril all the way to the nasopharynx. And we'll be familiar from our anatomy days of the nasal turbinates. These are essentially bony scrolls that are covered by a specialized mucosa, which causes the air to sort of move through these narrow passageways, through this little labyrinth. And there are a number of important physiological purposes for that. Furthermore, because the skull is dense, we have sinuses, and those sinuses function as empty spaces, and their function is to make the head lighter. So if the head was completely densely packed with bone, it would be quite heavy. And then the sinuses also play a role in conduction of sound, and also in the nasal passage function as well. So if we have a look at what the nasal passage physiological function is, we said we had the narrow passageways, and the purpose of this is to warm and humidify air so that you don't have cold or dry air being inhaled into the airways, and then very importantly to act as a filter or a dust trap which filter air. And this plays a very important role in the respiratory defense barrier And as the aerodigestive disorders, which are a group of diseases where we have pathology that arises, for example, in the respiratory tract and then has an impact on the gastrointestinal tract or vice versa, we're starting to realize how important these respiratory defense barriers are in pathology. And so we've got the mucociliary clearance system. So these are the small cilia that occur on the epithelial lining, and these cilia have a beating action which tends to drive mucus and then dust that's trapped in it, and also pathogens, and will tend to drive them away from the respiratory tract. And then also we have IgA, I beg your pardon, antibodies that are secreted here that also play a role in the defense. If we look at what this looks like in cross-section, you can see we've got a cross-section through the muzzle of a dog. We can see that we've got the nasal turbinates forming these sort of narrow cavities. And then it gives you an appreciation of what you need to navigate through when you are doing rhinoscopy, because this is a tight space. And then the main passageways, or the main cavities within this are referred to as the meatae, or the meatuses. So you've got the dorsal nasal meatus, which is normally too narrow to pass a scope through, and then you have the middle and the ventral nasal meatus. So generally, when we're passing a scope through, we're having to go through the middle and the ventral nasal meatus in order to get through to the back of the nose. So that's what it looks like in cross-section. Importantly, we also have done things to the nose of the dog, though, through breeding. And so the normal nose of the dog will be comma-shaped. And you can see that on a CT scan that we have a clear sort of comma-shaped opening through into the nasal passage. So this is the normal nasal opening of the dog. But of course, French bulldogs and pugs and English bulldogs have become very popular breeds. And so we commonly will see abnormal nasal openings. So the dog on the left has got a stenosis of the nasal passages of the nares. And on the right, you have a dog, which I'll show you in a second, that has had a narrowplasty performed, which you can see the edges of the nose have been resected, but it still hasn't addressed the deeper seated issues, which are the openings just caudal to that. So what this picture is showing you is this dog has had a narrowplasty performed, but if you look at the CT image on the right, just caudal to that, so a few slices deep from where that is performed, you can see there's virtually no opening at all through that nasal passage. And then if you have a look at the image below, that's one frame slightly rostral or slightly cranial. There you can see there is a slight opening, but you can see that in spite of the fact that this dog's nostrils have been trimmed, because the narrowing is deeper to just the openings, we still have significant impairment of airflow. And so unfortunately, we've been trying to get the sound to work on videos, but what this is showing is that this is the same dog. You can see the increased respiratory effort, and I will send through a copy of the PowerPoint afterwards, and you'll hear there's quite a loud stertor. Look at the effort of the nostrils there while he's trying to breathe in. So this dog has still got, in spite of having had BOAS surgeries performed, still has significant impairment of his of breathing. Now, this dog was presented for vomiting, which actually is regurgitation or reflux, and weight loss. So the presenting complaint from the owner is not the respiratory component, because owners that have French bulldogs and English bulldogs and pugs, they seem to think that loud suffocation in these dogs is normal. So the dogs will come in and they can hardly breathe, and the owners think that this is normal. Now, what's interesting in this dog is that the red circles on this image are showing you that this dog doesn't have any aberrant nasal turbinates, and the soft palate is actually quite nice and open. So the obstruction is at the level of the nostrils, not more distally in the nasal passage. So this is obviously completely anatomically abnormal. And these dogs have a plethora of problems, from regurgitation, reflux. They can have sleep apnea. They can have weight loss. They can have pyloric outflow tract obstructions. They can have a lot of issues, sliding hiatal hernias, all of which are related to their upper respiratory anatomy. Okay, so remember that we said the nasal passages are covered by ciliated epithelial cells. This is just a little image of one. And then we have goblet cells as well, which produce mucus. And this is how these nasal passages function. Now, I've showed a little video. This is taken from a textbook that I use, which just shows you what this looks like inside. So if we are looking inside the nasal passages, what do these nasal turbinates look like from an endoscopic perspective? So the little red dot here is showing you the route that the endoscope will take, moving through the nasal turbinates and ultimately being passed into the nasopharynx. So the red dot shows you the path that the endoscope will take so that you can orientate yourself. So we're entering the nasal passage now. We can identify the nasolacrimal duct. And then we move through into the nasal passage. We can see the nasal septum on the right. And then we can see at the top of the image, the opening there is the dorsal nasal meatus. So this is usually too narrow to pass a scope through. And then we move down into the middle and ventral nasal meatus. So moving on from there, we can see our nasal turbinates. This is a normal dog, so we don't have any pathology in this. And then we're looking down into the ventral nasal meatus, and we're also seeing the ventral aspect of the nasal turbinates. And now we're going to gently pass the endoscope through, just moving these nasal turbinates gently out of the way, and that will take us into the caudal part of the nose. So the part known as the choana, which is the back of the nose, and then ultimately into the nasopharynx. So this is a big dog. It's a Doberman. It has nice wide open passages. So we'll see the sphenoid sinus. We'll see the vomer bone. And then we can also see on the right of the screen where you see that's the opening into the nasopharynx. Now, so if you've identified all of these key landmarks, you know you've pretty much looked everywhere in the nose that you can with an endoscope. And you can eventually pass the endoscope all the way down. So those are your ethmoids. You can eventually pass the endoscope all the way down into the nasopharynx, and then you are confident that you've passed it all the way through. So we also have the sinuses, and they differ from sinuses in people in that dogs have got very big and well-developed frontal sinuses, but they don't have maxillary sinuses, the cheekbone sinuses that we have. They tend to have a recess there. And these sinuses are cavities that are air-filled. And so we can see in this image here, we can see a transverse view of the frontal sinuses in the dog, and we can see a lateral view of the frontal sinuses in the dog. And these are normal frontal sinuses. If we contrast that to our little aliens, the brachycephalics, you can see that the misshapen skull also comes along with abnormal shaped frontal sinuses and a very, very short nasal passage. And so we have those nasal terminids being condensed into a very small space, and that creates an obstruction to airflow. So this is just a little a diagram to show you the anatomy of the bulldog and how this contributes to airway obstruction. So we have narrowed nostrils. We often will have hypertrophied nasal turbinates that are crammed into a small space. The tongue tends to hypertrophy as well because the constant stertor and sucking causes thickening of the tongue. And then we also have the soft palate becoming thickened and becoming sucked into the laryngeal opening. So the cat has been interfered with less as a rule by breeding. We do obviously see Persians and chinchillas and other flat-faced cats, but the vast majority of our pet cats are not that dissimilar from their domestic ancestors. But the feline nasal passages are different in that the cat's nose, the feline skull shape, has a naturally shorter nose with much narrower nasal passages. So endoscopy or rhinoscopy in the cat can actually be quite challenging. You often will need a narrow scope, like a 1.9 millimeter scope, to access the feline nasal passages. So they are, it's difficult to do antegrade rigid endoscopy of the cat's nose, but getting into the nasopharynx of the cat is much easier because we can use a flexible scope to get into the back of that. I'll show you an image of that when we move on to the actual endoscopic technique. So that's the anatomy of the nasal passages. If we have a look at the anatomy of the airways, in broad terms, we've got the trachea branching into the left and main stem bronchi, and then branching into bronchioles, and then ultimately branching into alveoli. Now, when we have a look at dogs and cats, they have they have differences between the left and the right-hand side in terms of how their airways branch. And when we are doing endoscopy of the airways of a dog or a cat, we want to try and identify all of these airways. So on the right-hand side, we essentially have got 4 major branches that we want to identify. We want to identify the branch to the right cranial lung lobe, which is the first branch to exit on the right side. We then have the next branch being the right middle lung lobe, which is a branch that courses directly ventrally. This is why dogs and cats are susceptible to aspiration pneumonia, particularly in the right middle lung lobe, because that bronchus courses directly ventrally. Then we have the next 2 that will branch off will be laterally, will be the right caudal, and medially will be the right accessory. And then on the left-hand side, we've only got a cranial and a caudal branch, but the cranial lung branch will split into a cranial and a caudal branch. So you've got the cranial lung branch splitting into the cranial and caudal, and then you've got the caudal left lung branch. So this is what we want to identify. So these are a few images that are taken from normal cat tracheas. So a few things that we want to identify here is that we have the dorsal membrane. That tells us that this is dorsal, which is good, because when you're using a flexible endoscope, the scope might be lying over to the one side, and so when you're trying to orientate yourself and you want to know which way is up and down, it helps to be able to identify this dorsal membrane. If we then move a little bit more caudally, we can now start to see that we're in the carina. So this is the septum between the 2 main stem bronchi, and we have the left pulmonary branch and we have the right pulmonary branch. And already what we can see here is in this image, we can make out the opening to the cranial lung lobe. So as we move on a bit further, we can see this is the opening to the cranial lung lobe. And then this is the first branch that branches off, because as they branch further, they will branch into more and more branches. So it's basically like a tree branching away from you. And over here we have the opening to the rest of the right airways. And then in this image here, you can see we're still in the right-hand side. Here we now have the right middle lung lobe branch. Now, bearing in mind, this is dorsal, this is ventral. So this lung lobe goes directly down. So if you have mucus running or pus running through here or ingesta, it runs directly down into that airway. That's why we see with aspiration pneumonia, the right middle lung lobe is so susceptible. Then over here, we can see the accessory lung lobe branch, which is medially, and the caudal lung lobe branch, which is laterally. If we move on a bit further, we now have a closer up view. This is this is on the lateral aspect. This is the opening to the caudal lung lobe, and on the medial aspect, we have the opening to the accessory lung lobe. So that's on the right. If we move to the left is a bit simpler. So we're back to our carina, right side on the left of the image, left side on the right of the image. And you can see already you have got the cranial and the caudal branch. Cranial and caudal branch. But remember, the cranial branch will branch into two different airways. So as we move down, we will have the on the cranial side, we will have the left cranial and left caudal. So this is on the first lung lobe, and then we will have the left caudal lung lobe branch. So if you can identify those, and what I tend to do is I have a diagram, I'll go back to it quickly, on my endoscope. I have this diagram, and then I will try and make sure that I'm identifying all of these airways each time that I do a bronchoscopy. And then I'll try and go as far down each as I can, but I'll try and identify all of these airways. If I haven't identified all of these airways, then I don't feel I have had a good enough look. Okay, so that's the basic anatomy. Now, what do you need to go and have a look? Well, if you're going to do a complete airway exam, you're going to need a rigid scope and you're going to need a flexible scope. So for dogs, you need anything between a 2.2 to a 2.7 millimeter rigid bronchoscope, and then with a working length of about 10 to 14 centimeters. If you get a 2.7, you want to try and get at least a 14 centimeter working length, because some big dogs will have a relatively long nose. And then you also, when you buy your scope, need to take into account the width of the sheath, because the full width of the scope will be the width of the sheath. And when you are doing rhinoscopy, if you are doing it in a mucopurulent environment, you often are going to need a flush. So you want a sheath that has got at least a flush channel and a working channel so that you can flush the pathway while you are scoping. For cats, we really need a 1.9 millimeter scope. We can't really have anything much thicker than that. Otherwise, you're not going to be able to look in the rostral nasal passages. And then to look at the nasopharynx from the back, your best option here is to use a flexible bronchoscope. You essentially are going to, I'll show you an x-ray of it, of a scope in the nose. It'll explain it to you better. But you essentially are going to flex a bronchoscope so that it makes a hairpin turn, a 180-degree turn, and you're going to hook that over the nasopharynx, and you'll evaluate the nasopharynx that way. So from a flexible scope perspective, we want a working length of about 50 to 75 centimeters for our airway and a diameter of about 4 to 6 millimeters. Now you have deflection, that is the little handpiece that allows you to move the scope. And you have scopes that can move in 4 directions and 2 directions. 2-directional movement is fine for airways, because you don't need to insufflate the airways, and it's not as hard to drive around tight corners in the airways. So 2-way deflection is fine. And then you also need a channel for flushing or for your BAL. And remember, you don't need insufflation. You don't need to be blowing air out of the scope because the airways are open. They're not collapsed. And then what do you need? What accessories do you need? We always want accessories as vets, don't we? We want extra stuff. Well, if you want to do bronchoalveolar lavage and you want to make it simple, it helps for you to have suction, because then you can use a moisture trap or to suction through the scope, and the fluid will collect in a little moisture trap, and you'll be able to use that for your bronchoalveolar lavage. You don't have to have it. I don't actually use one. I just use a syringe and I suck manually. Then it helps to have some graspers or forceps that can go down your scope in case you need to grab something or take a biopsy. And then it also helps to have a cytobrush to go down your scope if you want to collect samples of the lesions. So to summarize, to do a complete airway exam, you need a rigid scope, and then you need a flexible bronchoscope. You could potentially use a small gastroscope, but then you have to start thinking about cleaning and sterilizing, especially if you're using your gastroscope in the colon. So it would be less ideal to be using that scope for an airway. Okay, so we spoke about the retroflexed view. We had a look earlier at the rigid view coming through the nose from rostrally. If you have a flexible scope, what you can do is you can flex the scope, retroflex it so that it has a 180-degree turn, and then you can pull the scope over the soft palate into the nasopharynx. And then what you are doing is you are looking into the back of the nose of the nasopharynx, and here you have the two openings into the nasal passage. And in this particular instance, this is a cat that has a grass blade in its nasopharynx. I very recently had a cat presented for gagging and stertor and possible coughing, and we removed a piece of wool of like thread from its nasopharynx using a retroflexed view and a flexible scope. So this is easy to do, and even if you have a bronchoscope and you don't have a rigid scope and you're doing bronchoscopy, you can at least look into the back of the nose, and you can look for pathology in the back of the nose. And sometimes if you have tumors or polyps, they will project into the nasopharynx, so you can at least see them from one side. If we look at the respiratory conditions that we will treat, nasal diseases, foreign bodies, aspergillus and masses or tumors are probably the most common. And then airways would be airway collapse, chronic inflammation, tears in the trachea, which are rare, but endoscopy is very helpful for that. And then also granulomas and masses. So I don't know how common this is wherever you are in the world, but this is a disease we treat quite commonly here in southeast Queensland. When I was up in the tropical part of Queensland, I used to see even more cases of these. This is sinonasal aspergillosis, which has been renamed from mycotic rhinitis because we wanted to have sinus in the name because it has a predilection for the frontal sinuses, and in some cases it's only in the frontal sinuses. It tends to give you a mucoid nasal discharge. It's more common in dolichocephalic dogs, so we don't see it in brachycephalic dogs as a rule. And another hallmark of this disease is I often see them and they've been treated with antibiotics and they've responded, and then the owners are lulled into a false sense of security. They think that it's bacterial, but invariably it comes back, and it's quite well reported that they will initially respond to antibiotics due to those secondary infections that they can get. And then on imaging, we see destruction of the nasal termidants. It's a very, very distinctive disease because what you see is these tough, pale, sort of really tacky plaques that attach to the nasal passage, and generally the nasal passages have been eaten out by proteolytic enzymes. So there's actually a lot of space in there, and it's quite easy to do endoscopy on these. And then sometimes we see them up in the frontal sinuses. And then we can also see foreign bodies. So this is an interesting case. This is not my image, but on the left was a rhinoscopic image of a leech in the nose of a dog that was removed. And on the right, this is also not my image, is a grass awn that was in the nasopharynx of a dog that was removed endoscopically. We can also see masses in the nose. So on the left is a nasopharyngeal view of a mass. You can see it on the left of the image, and on the right we can see a mass with a rigid scope from the anterior side of the nose, from the rostral side of the nose. So sometimes we can visualize these as well. And then this is rare. I know of a colleague who saw one of these up north, but you don't tend to see these so much now because of Brevecto and a lot of the anti-parasiticides that our domestic dogs are. But this was a case of nasal mites in a dog. So that's a rare case, but also something that you can diagnose rhinoscopically. Then as far as the airways go, common diseases that we would see would be tracheal collapse and bronchomalacia. Tracheal foreign bodies are rare. I haven't seen many in my career, and understandably because the airway is so well protected and dogs tend to cough if they aspirate anything. And we can sometimes see masses. So these are also not my images, but this is an image panel from the different subtypes of tracheal collapse from A to D, and what we typically see with these guys is we see that they have a loud, sort of harsh goose honking cough, and various degrees of dyspnea or difficulty breathing. Now, what's interesting in this image is you can appreciate all of this inflammation. You see all these prominent blood vessels here, and this is a very inflammatory disease. And as time goes by, we find that we can treat the vast majority of these dogs with medical management, corticosteroids and weight loss and environmental management, even the ones that are severe, because it's partly the inflammation that is causing the coughing, and that often causes the vicious cycle that results in the airway dynamically collapsing. So as time goes by, we stent less and less of these. Then another common disease is bronchomalacia or dynamic airway collapse. This is weakening or softening of the airways, and we see it coughing particularly in older dogs. And you might not see it on radiographs because it's dynamic. So if you don't happen to see it when the airways are collapsing, you might not appreciate it on x-rays. But you'll see it very, very clearly on bronchoscopy or fluoroscopy. So this is a dog that was a Cavalier King Charles Spaniel with chronic coughing. And here we can see on so this image is upside down. You can see the dorsal membrane was on the ventral aspect of the image. So right is right here, and then we can see the left. We have collapse of the left main stem bronchus. You can sort of see it opening and closing. So that's bronchomalacia, and that's a common cause of coughing in older dogs. If you do bronchoalveolar lavages on these, you'll often find low-grade inflammation. So you can sort of see how soft these airways are. This little dog did very well with pulse therapy of prednisolone and a fluticasone inhaler, and a little bit of environmental management and weight loss. Then this was a little dog that was presented that looks like a little chubby bunny with these basically a face full of air. So it had severe subcut emphysema. It was a dog attack victim. Here we can see subcutaneous emphysema. We can also see a pneumomediastinum here. So we've got a tracheal rupture, which we were able to identify on endoscopy, on bronchoscopy. Here you can see the circumferential tear, and I was able to tell the surgeon that there was no air bubbling through this, so we were able to visualize this dynamically, and we could determine that there was no active movement of air. And we treated this case conservatively, and this dog made a full recovery with just conservative management. And then we can also rarely see tracheal masses. So these are masses in the trachea causing an obstruction and coughing. So very easy to identify, and you can get a sample of those and biopsy them. Okay, so we've had a look at the anatomy. We've had a look at the different diseases. And now we're just going to talk about, I guess, some basic driving tips, or just some tips in terms of how to perfect your skills. So one, positioning. I tend to have them, I beg your pardon, I actually didn't notice this until now. I tend to have them on their chest, so in sternal recumbency for a rigid rhinoscopy. So I have them lying on their chest, and I often will use one of those rabbit gags to keep the mouth open so that I'm able to image the nasopharynx at the same time. And then what I tend to do is, if you've ever placed a nasopharyngeal tube, you do this blindly, and you basically pass the tube medioventrally. So I will pass the, if I can't really see what I'm doing, I will gently angle the rigid scope medioventrally, and I sort of follow the path of least resistance through those turbinates, and that'll often take you through into the nasopharynx. But obviously, if you've got, like in the video I showed you earlier, if you can watch where you're going, that's great. But most of the cases that you're scoping in the nose is because they have a nasal discharge, and then you often can't see where you're going. So sometimes you have to go a bit by feel. So this is an image to show you positioning. So this is a dog that has a rhinoscope being passed into the nasal passage. It's lying on its chest. I tend to have the head up, and I often will have a gag in, and I will always pack the pharynx with gauze swabs, and I'll always make sure that the ET tube is well cuffed and sealed, which is basically just what I've said. So cuffed, inflated ET tube, pack the pharynx with swabs. So some of the common pitfalls that we'll fall into is causing bleeding. So sometimes, especially when you're first doing this, or even if you've been doing it for a while and you get a bit blasé, you drive the scope into the mucosa and you cause bleeding. Sometimes it's unavoidable because it's a very crowded space, or there might be a mass. So if that happens, sometimes you have to just wait for the bleeding to subside and then maybe do a gentle saline wash and then go in again. Another common mistake is not to flush. So in some cases, particularly if you have exudate in the nose, if the scope is sitting in a pile of exudate, you won't see anything. So you'll have to continually flush to keep the pathway clear in order to pass the scope through into the nasopharynx. And then the other problem is sometimes the scope will be pushed up against the mucosa, and that will give you a readout. So the scope has to be looking into a cavity. It can't be up against the mucosa. So those are some of the common mistakes. Like we said, if there is a mucus or discharge, then flush the nasal passages first. The other thing that you can sometimes do is you can place a Foley's catheter into the nasopharynx and then flush the nostrils out and give it a good flush so that your nasal passages are nice and clean. And sometimes if you do that under pressure, you'll flush out a little tumor or you'll flush out a foreign body. So it's a very helpful procedure to use as a companion with rhinoscopy. Then with bronchoscopy, a lot of people will just scope through an ET tube because it's easy to feed it in. And then you normally will be delivering O2 through the side port of an ET tube. I actually don't like to do bronchoscopy through an ET tube because at some point you need to remove the ET tube to evaluate the parts of the trachea that are covered by the ET tube. So what I tend to do is I tend to induce the patient and then do my endoscopy first, and then if necessary, my anesthetist, or if I'm the vet, I can then intubate if necessary for recovery, if that's necessary. Often it's not. And so I prefer to do endoscopy without. The exceptions to that would be if I wanted to get a sterile sample and I placed a sterile ET tube and I want to pass the scope in without touching the mouth and the back of the throat, then I can go through the ET tube. But if I'm just evaluating the anatomy and I just want cytology, I don't normally scope through an ET tube. It's important to avoid driving your scope into the walls because you'll often pick up mucus that way. And remember, you can't really flush to keep your lens clean. If you do flush, you've got to do minimal flushing, unlike with gastroscopy or upper GI endoscopy or lower GI endoscopy. So you want to keep that lens completely clean. And then lastly, I just wanted to quickly talk about laryngeal paralysis. And so this is a fairly common condition. Oddly enough, today, my last case before I left work was a dog with laryngeal paralysis that I'm treating. And this dog has GOLP, geriatric onset laryngeal paralysis and peripheral neuropathy. It's a common condition where we have a polyneuropathy and we have hind limb paralysis, but then we also have a laryngeal paralysis. And so we see this in Labradors and Golden Retrievers, and it's due to recurrent laryngeal nerve dysfunction. So what we typically see is we see a stridor and we see exercise intolerance, and it's exacerbated by exercise. So unfortunately, I'm told we can't hear these videos. So this is a dog with an upper respiratory stridor. We can see there's dyspnea. And then this is a dog that had neck surgery, and there was a possible transection of the laryngeal nerve. So if you listen to this, I'll have these PowerPoints sent through so you can actually listen to the audio. So there's a couple of different ways you can diagnose it. Visual inspection is probably the easiest. You just have a look at the larynx if you can see it. Some dogs with a really long mouth, you can't actually visually see in the back of the throat. And then endoscopy can help you. You can just use the scope to visualize it. You want to do it with a light sedation and anesthesia, because sedation and anesthesia can affect the movement of their retinoids. But visual inspection is probably the easiest. Some people can do ultrasound. They can scan the ventral aspect of the larynx and they can actually view the arytenoids moving. I can't do this. I find it very technically challenging. But the advantage of this is if you are a very flash hot sonographer, is that you can potentially do this in an awake patient. So this is a St. Bernard that was presented with epileptic seizures and an aspiration pneumonia. And if you listen to the video, you'll hear that he's got this marked upper respiratory stridor. And when we evaluated his airway, you can see on the right of the image, which is the left arytenoid is moving. And if you look at the left of the image, which is the right-hand side, you see there's no movement there at all. And basically, most of these cases are managed conservatively. Surgeons often don't like to do the surgery because of the risk of aspiration pneumonia. So exercise restriction, weight loss, environmental modification, not using collars, avoiding the heat of the day, keeping them quiet. These are all the things that you would tend to do. And occasionally low doses of corticosteroids can help too. From a surgical perspective, tiebacks are an option, and also permanent tracheostomies. So I hope that piqued your interest and got you excited to do upper airway endoscopy. And yes, if there are any questions, I'm really happy to answer them.
Okay, thank you for Dr. Burchell's presentations. It enabled us to experience the rich and vivid context of the animals in endoscopy. Let's move to the question and answer session, in which you could raise your hands or share your question with Dr. Richard Burchell in the chat box. Okay.
Hello, Tiffany. I know Tiffany. No, I don't. Maybe for cats, if that's what you meant, then absolutely, terbutaline. but not for dogs. And dental blocks, well, I've done both. I'm generally not the anaesthetist in my in sort of my area of practice, and I've worked with anaesthetists who are ardent dental blocks for rhinoscopy. I personally don't find it makes a huge difference. I find it just adds time to the procedure, but that's just my personal opinion. I can understand the rationale for it, that you're trying to lower anesthetics, but or lower the amount of anesthetic that you need in order to be able to perform it. But I must be honest, it's not really made a noticeable difference for me. Would you like, sorry, I don't want to butcher your name. I'm going to call you Alu. Sorry, or Dr. Amin. That'll be easier to say. Would you like me to go back to the slide and go through it with you? Okay. Is my screen still sharing with you guys or not? No, I don't think so. Let me share it again. Okay, you can all see that. Okay, so you've got the trachea, and then you have the carina over here, and that'll branch into the right-hand side and into the left-hand side. So this time around, I'll start with the left because it's more straightforward. So you've got the left pulmonary branch, and then you have a left cranial and a left caudal. And then as you move, you'll see that they divide. So you've got left branch 1, division 1A. So they branch further, but we want to identify the major airways. So we've got left cranial here, and then the left cranial branch will subdivide into a cranial and caudal branch. So left cranial branch subdividing into a cranial and a caudal branch. Then we've got the left caudal branch. So these are the main divisions of the airway. On the right-hand side, if you're coming in and the image is aligned so that dorsal is the top of your screen, to your left, there'll be a sharp curving airway, which will be the right cranial lung lobe. The next one will be the right middle lung lobe, which will course directly ventrally. And then moving on from that, you will see the right accessory and you will see the right caudal. So what that looks like is, as you come to the bifurcation, here you have right cranial. Okay, that's the left-hand side. That's the right-hand side. Then moving down, we have right cranial still. We've got the opening to the other airways on the right-hand side. The next one down will be the right middle. And then in the distance here, we can see the accessory and we can see the caudal. And if we have a closer up view of that, we have accessory coursing medially and we have caudal coursing laterally. And then those will further subdivide. So they continue to subdivide, but those are the major divisions you want to see. Then we're moving back to the carina. So now we have the left-hand side. And as we move into the left-hand side, we have got a cranial and we have a caudal branch. And if we move into the cranial branch, we will see that it subdivides into 2 further branches, a cranial and a caudal branch. And then there we have our caudal branch. So those are the basic airways that I'd like to try and identify when I'm doing bronchoscopy, because then I feel like I've seen at least each division of the lung. Does that answer your question? It's my pleasure. There is a very nice video in the textbook of veterinary internal medicine, Ettinger textbook of veterinary internal medicine, in the current and the previous edition, that shows the access to those airways quite well. Sorry, I didn't see your other question. So I tend to use butorphanol and medetomidine most of the time, unless they're cardiovascularly unstable, and then induction with alfaxan or propofol, depending on what the anaesthetist's preference is. I think that the problem is that, and I'm not quite sure, Ahmed, what your setup is, whether you're doing it yourself or whether you have someone separately doing the anesthetic. But what I find, particularly in referral practice, where you have somebody else doing the anesthetic, is the person doing the anesthetic always wants them to be super light. And I find that it's a common problem that they are waking up when you are doing cystoscopy or rhinoscopy, because it's a very sensitive part of the anatomy. So I think it's just making sure that the anesthetic plane is that they are deep enough, and if they are deep enough, then generally it's not a problem. And Tiffany asked about the nerve blocks, and I've worked with anaesthetists that swear that it makes a difference, but what I've often found is that anaesthetists that do the nerve blocks, these are always the ones that are sneezing the scope out, because then they want to get away with a super light kind of anesthetic. I think they just need to be deep enough.
Okay, so any other who has the question, you could raise your hand and share your questions with Dr. Burchell.
Yeah. Something else, sorry, just while people are thinking of questions, I think something else that there's a huge value in airway evaluation is, and I'm sure that wherever everybody is, that French bulldogs, English bulldogs, pugs, the flat-faced dogs are popular. They are very popular here. And we find so many aerodigestive disorders. So dogs that have got reflux, that have got thick and soft palates, that have got regurgitation and gastrointestinal signs as a result of their airway disease. And so we will try and evaluate their, look, we obviously use CT to evaluate their airway as well, but I like to evaluate their airway to identify aberrant turbinates, but also to identify sliding hiatal hernias. So I will put a scope into the esophagus, and then I'll occlude the ET tube and get them to breathe against some resistance to see whether there is a sliding hiatal hernia, because it gives you a good overview of the interplay between the respiratory system and the gastrointestinal system. So yeah, it's a very valuable tool, particularly in assessing. I mean, I know that look, I'm an internal medicine specialist, so I'm not surgically fixing BOAS, but I do think that if you are a surgeon or you're a person who only focuses on surgery, you're missing a bit of a trick with managing these BOAS cases, because they often need some good medical management as well.
Dr. Burchell, there is another question by the
pet. Oh, sorry, I just missed that. I'm having a look at it now.
Okay. The chat box.
So yeah, so I guess probably the simple answer to your question, Dr. Nanda, is I'm often not really doing these in critically unstable patients. I think you have to be, I guess it's a very broad topic, because you might be doing an airway exam because you have a collapsed trachea and you're wanting and the dog is dyspneic, and under those circumstances you probably want to avoid anesthesia and endoscopy unless you have an emergency stent that you can place, because often you can't recover those cases once you've done endoscopy on them and they've been under anesthetic. So I generally avoid the respiratory distress patients for endoscopy. I probably, and it's going to depend on the cause, but for example, if you're wanting to get, say, you're concerned that there could be a bacterial pneumonia and you want to get a sample for culture or cytology, I'd be more inclined to do a lung aspirate on those cases with ultrasound guidance than to go and put an ET tube and potentially do a lung flush. But in broad terms, you would obviously do things like pre-oxygenation. Make sure that they have oxygen. So if you are concerned about oxygen and you don't have the ability to have the ET tube delivering oxygen, then you can place a feeding tube into the trachea with oxygen connected to it and scope alongside that. Or you can connect the oxygen directly to your endoscope and actually flush oxygen through the endoscope, through the working channel of the endoscope, to provide oxygen that way. And then under those circumstances, probably the most important thing is that your anesthetic is as short as it possibly can be. So you've got to be quick.
Okay, thanks for your reply.
那个聊天框里面好像还有，是啊，到时候有个，
就是这个，刚刚已经回答了。
刚回答的是问答里面的。
Okay, and another question is from the Pet Minute.
Mm-hmm.
Yes. They ask, can we use the same probes that we use for rhinoscopy to go to the trachea, maybe? Trachea. Can you see the chat box?
I can see the chat box, but I don't see that one. Did I miss it?
Can we use the same probes that we use for rhinoscopy to go to the tracheas?
Yeah, but it would depend. Yes is the short answer, but you're probably not going to be able to get very far. So you certainly would be able to evaluate, and it depends on how long your scope is, and it also depends on the size of the patient. So you should be able to see the larynx, you should be able to see the proximal trachea, but you might not get very deep down. I actually think, and I mean, it depends on what you've got already, but I think if you were going to buy a scope, you'd be better off actually learning to do rhinoscopy with a small flexible bronchoscope, which I have done in the past, because that would be more, have wider applications than if you have a rigid scope. So the short answer is yes, you can, but you're going to have a relatively limited ability to see the whole airway, because you can't really maneuver that scope. But then obviously with rigid scopes, you get such wonderful resolution because those are glass. It's not a digital image, so it's an actual physical image. So you get really, really good quality images with your rigid scopes.
Thank you for your Dr. Burchell and our participants. And another question is, do you pre-meditate with the bronchoscope? Sorry. Okay, I will send to the chat box.
Yeah, sorry, I can see that now.
Okay.
There was I can see that there's more questions. So
and Tiffany.
Yeah, so I've seen that. So is oxygen necessary to see lungs in large animals? I haven't done that so it's not really my area of expertise. I think the principle is pretty similar. It's simple. How much of the tracheal lumen is your scope occupying? if there's enough space around your scope that the animal can breathe past your scope, and you're monitoring its clinical status, then I don't think you have to have oxygen. I don't always use oxygen if I'm using a narrow bronchoscope in a big animal that's able to breathe. So I think that's the short answer from a principle point of view, but it's not really something that I really treat. And then major bleeds for rhinoscopy was another question. Yes, you can. I don't generally get them with rhinoscopy, but I do get them with biopsies. What I tend to do if I get a bleed is I try to first, I'll pack gauze swabs into the back of the nasopharynx, into the choana to occlude the nose at the back, and then I'll often put swabs or Q-tips into the nasal passages, so that you've essentially confined the bleeding into the nasal vault, so that it's because in theory, if you can occlude it from both sides, it can't bleed beyond that. But then I've also used and pardon me if I forget the name of it because I'm not a surgeon. I've also used the gel foam that the surgeons use to stop bleeding. But mainly it's physical occlusion to the best of my ability. Some cases I've even put a Foley's catheter up into the nasopharynx to completely occlude the nasopharynx. So those are some of the things that I will do. I've only seen, one dog over my career. Fortunately, it's not that it makes a difference. It wasn't a scope I was doing. It was one that I was watching, where a dog bled to death after a nasal biopsy, but that was a greyhound and probably a hyperfibrinolysis case. So yes, they do bleed, but it is quite rare to have life-threatening bleeding. I think probably what's more important is to try and identify the risk of bleeding prior to taking biopsies, and just to think about how important those biopsies are. So, for example, if you've got a dog that has got a lot of oronasal fistulas or a lot of bad teeth, you might want to treat the dental disease first and get on top of that before you consider taking a nasal biopsy. And also it depends if you've done imaging. So if you've done imaging and you think you've seen a mass or turbinate destruction, then it's really worth getting a biopsy from that, because then that can obviously has a big impact on the diagnosis and on the outcome of the case. But yeah, those are some of the things that I've used is physically occluding the nasal passages.
Can you see the latest question from the Dr. Wellist, maybe? Please, you can repeat the anesthesia type which used during bronchoscope.
Yeah, so I generally will use butorphanol and medetomidine, but I use a very low dose of medetomidine, so 2 microgram per kilo, and then either alfaxan or propofol. And then usually, for rhinoscopy, they're obviously intubated and they're maintained on isoflurane or sevoflurane, whatever you've got. But for bronchoscopy, normally this is done within about 5 to 8 minutes. It's not a very lengthy procedure. And I like to do endoscopy directly into the trachea. I prefer not to do it through an ET tube. So in some circumstances, I won't intubate them. I might just intubate them if they need to be under gas for a while, if you're just wanting to get them stable, or if you're wanting to do anything else to them while they're under. So yeah, that's what I would do. And I pretty much use that anesthetic protocol on most of my procedures. For GI endoscopy, so if you're doing the esophagus and you're trying to get into the duodenum, you want to avoid methadone, because that's been shown to make it more difficult to get into the duodenum. But it's not really relevant for bronchoscopy. But these are not normally painful procedures, so I don't normally need the methadone or morphine or fentanyl spectrum of pain control. I just want the sedation from the opioid.
Okay. Is reliable if used ETs with bronchoscope?
If I understand the question correctly, the issue is that when you scope through the ET tube, you can't see the trachea that's under the ET tube. So if you had inflammation or if you had a lesion, particularly, it's rare, but sometimes you'll get a squamous cell carcinoma in the larynx or in the proximal trachea. And so, you know, especially if you've got like a brachycephalic dog or a dog in which you are accustomed to intubation being a bit difficult, your anesthetist or your vet nurse or whoever's doing it might push the scope in and not appreciate that there's a lesion there. So you scope and you can't see that because it's covered by the ET tube. So if you, what I'd say is if you're learning and you don't want to be under pressure to be, you know, where you feel like you need to do it quickly, then scope the lower airways, have a good look at them, do a thorough job through the ET tube. But then when you extubate, have a look at the airway that was underneath the ET tube so that you've at least had a look at the whole airway. How you do that doesn't really make a big difference. Whether you do that, look at the proximal trachea first and then intubate them and then go deeper into the airway, it's really up to you. I think the principle is just to know that if you've only scoped through the ET tube, you haven't seen the whole trachea, particularly if you've fed it all the way down to the thoracic inlet.
Okay. Thank you for your question and your answers. And another question from the Mr. Bolt is oxygen necessary to see lung in the large animals?
Yeah, I think I answered that one, which was that it's not, obviously I don't scope large animals, but the principle is just how big your scope is. So if your scope is occluding more than 50% of the trachea, that it's going to be difficult to breathe past it, then I think you do need oxygen. But if you've got a scope that there's plenty of room around the scope that the animal can breathe in, then I don't think that oxygen is imperative.
Okay. Okay.
It's my pleasure.
If we don't have any other questions, we would stop our webinar today. Okay, thank you for all participants today, and also thank you for our Dr. Burchell for such an informative and engaging session. We have learned the techniques for the challenge airway case and the roles of the endoscopy in respiratory diagnostics. And big thanks to everyone who participated. Your attendance made this discussion truly valuable. If you have any question, don't hesitate to reach out to us and our Dr. Burchell, and stay tuned for the follow-up email with the webinar's recording and additional resources. You can contact our emails. I will send our emails to the chat box as well as the Dr. Richard's emails to the chat box. And we will share the PowerPoint files and the recording video to you after that. Thank you for your attendance. Have a wonderful day. We look forward to seeing you at the future event. Goodbye. Thank you.
Sent you a link for the PowerPoint.